Hello, good day, everyone. I'm Chief Su from Taiwan Medical Mission in the Republic of Somaliland. Here today, we are going to explain about the airway management, which is basic in our every daily life practice. Hope today we will be able to learn how to evaluate the patient and how to manage if the patient having respiratory distress and what kind of weapon means the apparatus we have and how to manage the patient. So here we go. So firstly, we should evaluate the patient if we see them in respiratory distress. We will see the patient, we will hear the patient, we will feel the patient, and we will measure the patient. Firstly, what to see? We want to see if the patient is having a cyanosis and how is their respiratory rates, if there's any accessory muscle usage, and if the patient is breathing fast and shallowly. If that's the case, we should be aware of if there should be some respiration problems. Here, what should we hear? We should hear if there's a wheezing or stridor and osculate the breath sounds. So about the breath sounds, what are you expecting to be heard? Maybe we can hear some roars, crackles, and above mentioned wheezing or stridor. Those are signs of some pathology happening inside the lungs. Thirdly, we feel. What do we feel? We use our hands. Maybe we can feel the subcutaneous emphysema if the patient is having a pneumothorax or rib fracture. We can feel the vocal fragments, which is can distinguish the pleural effusions. And also, if the patient having chest trauma, we can feel the crepitation of rib fractures. Lastly, we use some gadget to measure the patient's condition. We can measure the vital signs, we can measure the level of consciousness, and also the most often used is the saturation of the pulse oximetry. Yeah. Then we talk about pulse oximeter. Pulse oximeters use infrared beams to detect the erythrocytes as we saw the red blood cells in the capillaries in our fingers. The erythrocyte carrying oxygen will absorb more infrared beams with 850 to 1000 nanometers, and those not carrying oxygen beams will absorb more infrared beams with 600 to 750 nanometers. So they can differentiate how many erythrocytes are saturated with oxygen inside the capillaries. That's how the information was given to us. But something still will interfere with the detection of the infrared, such as the nail painting and deep color or coldness will also affect the measurement of pulse oximeter. So there will be one problem. We know how many methods that we can evaluate the patients. Then there's a triology to evaluate the patient in respiratory distress. Firstly, we will evaluate the patient about the airway. Okay, so the triology of respiratory evaluation will be airway, secondly, drive of respiration, thirdly, oxygenation. So now we are talking about the airway. Okay, so during the airway evaluation, we will evaluate the patency of airway. We will try to open the airway, and if the airway is still obstructed, we will use the accessory airways. Okay. So, firstly, we will evaluate the patency of airway. In a normal person like us, usually when something goes into our airway cause obstruction, firstly, we will cough, but with ability to talk. But if the food or the debris scope is bigger and obstructs further, we will present it with hoarseness. And if it go further, we will not be able to make sounds. So that's the obstruction level gradually become more severe. So if you see in the patient or who is able to cough and able to talk, then that's the least level obstruction. We can ask them, we can encourage them to cough out. And still, if they present it with hoarseness, we can still encourage them to cough. And last, if they cannot make sounds, then we will introduce later. We will try to do the helmet maneuver, which can help them during the airway obstruction. And there's one question. If you see an intubated patient with endotracheal tube or laryngeal mask, but the respiration or the venting is still having problem, how do you know it's blocked or not? Okay, we will talk about it later. That's no problem. Yeah. If the patient's airway is obstructed, what will you do? Okay, firstly, we will try to open the airway. So there are several maneuvers to do that. The most often used is head tilt and chin lift. Head tilt and chin lift. You can see the pictures. During head tilt and chin lift, the tongue, usually when the airway obstruction develops, sometimes it's caused by the tongue drop. And if you do the head tilt and chin lift, will be okay to open the airway and make the tongue not dropping back. But because you can see that the cervical spine is moved a lot during this maneuver, so it's not suitable for patients with neck trauma. And during patients with trauma, what can we do? We will talk about it in the next slide. The other way to open the airway is the jaw thrust. Jaw thrust will use your hands, put on both your palm on the maxillary area of the patient and use your fingers to lift the mandibles. And during this maneuver, it will also help with the patient's obstructed airway, but the cervical spine is less moved. Okay, so when we talk about the patient with food or other things, foreign object obstruction, we can do the Helmick maneuver. It's developed by a doctor named Helmick, and he actually used that to help patients with obstructed food obstruction. So during the patient with the least two obstruction level, with partial obstruction with clear consciousness, we should encourage the patients to cough, to spit out the foreign body, and close up observe the patients. But in case of total obstruction and the patient cannot make sounds and become the face is red and cannot make sound or cyanotic, then we should do the Helmick maneuver. During Helmick maneuver, you will use one hand making a fist, the other one covered over the back, over the button of the fist, and use put your fist on the patient's uh, xiphoid process and move upward and backward until the two conditions develop. Firstly, is the patient cough out the foreign body. Secondly, is the patient lost consciousness. If the patient lost consciousness, then we will do CPR. That's another thing. We will talk about that during the adult BLS. Yeah. So that's what we do. Use one hand has fist, one hand put on the back of the fist, put it on the xiphoid, under the xiphoid process, and push upward and backward, until the patient cough out the foreign body or the patient lost their consciousness. Okay, so if the airway patency is still having problem, then we will consider and use the accessory airway. So the accessory airway, we have two choice. Firstly is the nasopharyngeal airway. Secondly is the oropharyngeal airway. For the oropharyngeal airways, for those unconscious patients. Why? Because the oropharyngeal airway will go to the oropharynx, which might cause vomiting. So, for those with consciousness, maybe partial consciousness, and still having gag reflex, we should not use the oropharyngeal airway. And we should measure the length that we want to use properly. We will measure the oral angle to the earlobe for the proper size. So when you want to put it, you put it in reversely to the mouth and turn 180 degrees till the end. Okay, so yeah, if we have chance, you can practice that. And for those patients with patent gag reflex, which is nasopharyngeal airway, yeah, because it will cause less gag reflex and um, will not cause that much discomfort. Yeah, so also we should measure the size. The size is from nose tip to the earlobe. And the contraindication is that the possibility of basal skull fracture or maxillofacial trauma, because in those cases, you might put the nasopharyngeal airway into the brain or into the sinus, which will cause more problem to the patients, which should be avoided. For those patients, we had opened the airway, we had inserted the accessory airway, but the patient is still in the respiratory distress and with no much improvement, then we should consider about establishing the advanced airway, which including the laryngeal mask, laryngeal tube, the esophageal tracheal combi tube, and endotracheal tubes. Firstly, we will introduce the laryngeal mask airway, which will look like that. And it's like a balloon inside will obstruct the esophagus and get that airway the air go into the trachea. Okay, so the size is from 1 to 6. For adult male, the size is around 4 to 5. And for female will be around 3 to 4. Okay, so the size 3 is for about the body weight about 30 to 50 kilogram. The number 4 is for 50 to 70 kilogram. And number 5 is for 70 to 100 kilogram. And because it's just like a balloon, so you should inflate some air inside the laryngeal mask to make it obstruct the esophagus. So the inflation amount will be the size -1 and multiple by 10 cc. So it means that if it's number 4, we should inflate about 30 cc into that for proper insertion of the laryngeal mask. Okay, and laryngeal tube and the combi tube are similar method, but with similar apparatus, but with a different mechanism. Okay, lastly will be endotracheal tube. So we will talk about intubation later. And firstly, we just see that, okay, let's open during the triology of respiratory evaluation, if the airway is secure, or you confirm that there's no airway obstruction, but the patient is still in respiratory distress, then we should check the drive of respiration. Okay. So if a patient's airway is secured, and we confirm that there is no airway obstruction, but the patient is still in respiratory distress, we should sort for the problem of the respiratory drive. Usually we want to evaluate the patient with insufficient or respiratory drive or imminent respiratory failure during this step. Firstly, we will find the patient if they are breathing too fast or too slow. For those patients, we are saying they are breathing too fast, means that more than 30 breaths per minute. Those are too slow at less than 10 breaths per minute. And also, a patient with imminent respiratory failure may have a weak flow and use of accessory muscles. So on the right side picture of a patient with emphysema or COPD or asthma, when they have effort for breathing, they will bend forward and a rounded mouth and may have sweat on their foreheads, which means that they are breathing forcefully and there it's possible they are going to have a respiratory failure due to muscle weakness. Or in case of insufficient respiratory drive, what should you do? You should help them to give them a breeze. How to give them a breeze? In the old times, we use mouth to mouth, but not now anymore. Now doing the bag valve mask for begging, for giving the patient a breeze. So during BVM, we will give 10 to 12 per minute. It means about every 5 to 6 seconds. And the ventilation amount is about 6 to 7 milliliter per kilo. It means about 400 to 600 cc every time. So don't hyperventilate the patient and don't inflate too much to cause the barotrauma of the. Okay, so now we are talking about the bag valve mask, BVM. We use the BVM during insufficient ventilation or no respiration, which can help the patient with the respiration. Usually, it's in three sizes, with neonatal size, children size, and adult size. And if we use the BVM only to give the room air, it will deliver about 21% of oxygen concentration. But if combined with a reservoir, can deliver 90 to 100% of oxygen. And it also could generate positive pressure to force the air into the lung. And if you use the mask properly, it can cause the positive ventilation and will help with the patient's breathing and also will open the lung. So here is the picture of how to apply the mask. Remember, properly seal the mask with the patient's face will help with the usage of bag valve mask and is very essential to the usage of BVM. Yeah. And lastly, if the airway is confirmed patent, the drive of respiration is corrected, use the BVM, and the patient is still in respiratory distress, then we should consider administer oxygen to elevate the concentration of oxygen inhaled. So the step, one by one. If the airway is patent, the respiratory rate is more than 10 per minute, but the patient is still cyanotic or is for respiration. Yeah, so there could be the problem that in the lung causing the problem in oxygen exchange, including pneumonia, pulmonary embolism, heart failure with pulmonary edema, or shunting. In case of insufficient oxygen supply or exchange, we should elevate the O2 concentration. That's what we should do now. So the oxygen delivery apparatus, including the nasal cannula, simple mask, non-rebreathing mask, or the MRN, and Venturi masks. I think we have them all except in the Venturi mask. For the nasal cannula, it's more comfortable because here we're not having a mask over the patient's face, but the nasal cannula can deliver lower oxygen concentration. It could provide 21% to 45% of oxygen, means the fraction of inhaled oxygen. And every 1 liter per minute increment in the flow will cause 4% of increase in the FiO2. So when we give 1 liter of nasal cannula, which means we are giving 25% of FiO2. 2 liter means 33% of FiO2. So that's the 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 how the concentration can deliver by the nasal cannula. But we suggest that no more than 6 liters per minute because it can cause discomfort and epistaxis. Yeah, because usually the oxygen is dry, and if the um the oxygen is too dry and too fast, which will cause the um nasal mucosa to bleed. So, and also will make the patient feel discomfort. So we suggest that the flow should not more than 6 liters per minute. Okay, let's talk about simple mask. When during using a mask, no matter is simple mask or non-rebreathing mask, we suggest that no less than 6 liters per minute. And because that both masks could cause the CO2 retention. And we suggest that simple mask will start from 6 liters per minute up to 10 liters per minute. And also it's the same, 4% of FiO2 increase by each 1 liter per minute increment. And it could deliver the O2 concentration between 45% to 60%. And we suggest no flow under 6 liter because it could have the carbon dioxide retention effect. Okay, yeah. And Venturi mask, here comes the Venturi mask. Venturi mask means it can use the Bernoulli's law for precise inhaled FiO2 adjustment, but usually it will cost more, and it was less used. And here, what we see is the non-rebreathing mask, abbreviated with NRM. And MRM are for those who need high oxygen concentration. The patient may have desaturated or carbon monoxide intoxicated. So non-rebreathing mask could give up to 100% of oxygen, and the flow should adjust to the point that the reservoir will not fully collapse after each inspiration and could inflate well before next inspiration. So the fraction of inhaled oxygen will be 60% with 6 liters of per minute flow, and may up to 100%. And you can see the picture on the right side. What's the problem of the usage of this NRM? So remember that to adjust the flow to the point the reservoir will not collapse. So in this picture, the flow, the reservoir is totally collapsed, which may cause the patient not able to have enough tidal volume for him. So remember, the reservoir should not be fully collapsed after each inspiration and should be able to inflate well before next inspiration. So in conclusion, in the triology of respiratory evaluation for the patient with respiratory distress, firstly, we will evaluate the airway patency. If suspecting the airway is obstructed or the patient is unable to protect the airway, we will try to open the airway and establish to secure the airway. If the airway is secured but patient is still cyanotic or effortful breathing, we will try to evaluate the drive of respiration. If the patient is in imminent respiratory failure or with insufficient respiratory drive, we will give supplemental breathing by using the back valve mask. But after airway secured and the drive of the respiration is supplied, the patient is still cyanotic, we should consider if there's any problem in the oxygen exchange in the lung. So we can elevate the oxygen concentration. So that's the triology of respiratory evaluation, including airway, drive respiration and oxygen. And then we will talk about intubation. For those patients with imminent respiratory failure or cannot protect the airway, usually we will have to intubate the patient. And rapid sequence intubation can help us during the intubation process. But yes, then the advantage of rapid sequence intubation, including better patient comfort and less fighting during intubation. And for us, will be easier intubation process. And for the patient, we'll have less sympathetic excitation and will decrease the chance of aspiration pneumonia or hypoxia. And what's the contraindication of RSI? Firstly, if the patient is an anticipated difficult airway. And secondly, if the patient cannot maintain adequate saturation of oxygen and the back valve mask support, we should avoid the RSI. Yeah. Talk about difficult airway. How to evaluate the patient is having a difficult airway. There's a mnemonics lemon. Firstly, L means look externally. E means evaluate using 332 rule. M means Mallampati classification. O means obstruction, and N means neck motility. So the firstly will be 3-3 rule. 3-3 rule means that you can use 3 fingers. As the patient open the mouth, you can put 3 fingers between. And the mandible to hyoid bone having 3 finger lengths. And hyoid bone to thyroid cartilage with 2 fingers width. If the patient can comply with all of that, maybe the patient is not a difficult airway. And Mallampati classification, you ask the patient to open the mouth if you can see the uvula and the posterior pharyngeal wall well. That's class 1, will be relatively easy and will become relatively difficult if the position of the uvula and the clarity of the view of laryngeal wall will become 2 to 4, means the patient might have a difficult airway. And when you evaluate the patient and want to do the intubation, remember to ask ample before you intubate the patient. First, A will be allergy, if the patient having any food or drug allergy before. M means medication. What medication is the patient using now? What kind of medication being given to the patient? P means past history. What kind of past history is the patient having? Is the patient having diabetes or hypertension? L means last meal. When did the patient eat last time? And E means event. What caused the patient to be here? Why he should be intubated? And that's remember to what we should remember to ask. Ample, allergy, medication, past history, last meal, and event. And before intubation, we have to prepare something, including the mnemonics is SOAP me. SOAP means suction, oxygen, airways, pharmacology, monitor, and equipment. And the equipment, remember to use proper size of laryngoscope, and the tracheal tube in endotracheal tube in male should be 7.5 to 8 French, and for female will be 7 to 7.5 French. And balloon should be tested for patency and give some proper lubricant with the jelly. And lastly, the stylet should be in place for proper position of the tip of the endotracheal tube. And it should not protrude outside the endotracheal tube. Remember that. Okay, so during the rapid sequence intubation, the sequence will be firstly put the patient on the bed and give pre-medication. And those medications will be easier remembered as load. And then we give sedatives. After the patient falls asleep, then we give muscle relaxant, and then intubate the patient, and lastly confirm the placement. So the pre-medication. The pre-medication, the mnemonics is load, including lidocaine, opiates, atropine, and devasculating agent. So I will not talk too much about that, but remember that those pre-medication will improve the comfort of the patient, also will help with our intubation. And for the sedatives including the ketamine, the midazolam, etomidate, or propofol. I think midazolam and the propofol are more often used in our ICU in Hagisa Group Hospital. And midazolam is kind of benzodiazepine, which is fast-acting and short duration. And the dose will be 0.07 to 0.3 milligram per kilo IV push. And for propofol is also fast-acting, but it might have some BP lowering effect and injection site pain. The dosage of propofol will be 2 to 2.5 milligram per kilo IV push. After the sedatives, after the patient have fallen asleep, then we can use the muscle relaxant. The choice of muscle relaxant including depolarizing agents and non-depolarizing agents. The depolarizing agents most often used is succinylcholine, which is 1 to 2 milligram per kilo IV push. It's fast-acting, but sometimes it could increase the IICP or intraocular pressure, and also cause the elevation of potassium, sometimes could cause bradycardia. So non-depolarizing agent may be a safer choice. I often use the rocuronium as the non-depolarizing agent. The dose is 0.6 to 1.2 milligram per kilo. It has no muscle twitching effect and also have an antagonist. Yeah, so sometimes the non-depolarizing agent is more often used, but of course it's more expensive than the depolarizing agents. Yeah. After you paralyze the patient, and then we will intubate the patient. After intubation the patient, we should confirm the placement. Okay, we have 5 ways to confirm the placement, and we should use at least 2 methods to confirm it. The first way to confirm the placement will be osculation. We should osculate 5 places: bilateral apex, bilateral lower lung field, and the stomach area to confirm it's not esophageal intubation. Secondly, we can use the capnography. It will measure the end-tidal CO2. It means that we will measure the carbon dioxide exhaled from the endotracheal tube. And if the carbon dioxide is detected, then we can confirm that the endotracheal tube is put inside the trachea. And thirdly, esophageal detector device, EDD, but it's lessly used now. Fourthly, we can use the chest X-ray to confirm the position. The tip of the endotracheal tube should around 2 to 3 centimeters above the carina. And we can see if the endotracheal tube is intubated, is placed in the right place. And lastly, ultrasound can also be used to assist the intubation process. Ultrasound can see if the endotracheal tube goes inside the esophagus. So that's the way how we confirm the placement. And remember, use at least 2 methods to confirm the placement. And when we talk about the capnography, it will measure the exhaled expelled carbon dioxide, and it will be more accurate after 6 bagging. Means 6 bagging means that 1 bagging, 2 bagging to 4, because sometimes the esophagus may have some retained carbon dioxide. And after 6 bagging, if um, the reading will be more accurate as to confirm the placement in the trachea. So here, this is the end of um, our lesson, and we hope you to remember the triology of respiratory evaluation. Remember the steps of evaluate airway patency, to evaluate the drive of respiration, and lastly, to um, evaluate the oxygen exchange, and then how to establish the airway, how to intubate, how to do RSI. And we hope that you have learned something today. Thank you.